And welcome to our live stream from Deuk Spine Institute. It is September 12th, 2023. Our first patient is having 3 different areas of his discs fixed. He has herniated disc with annular tears, back pain, leg symptoms from pinched nerves at L3-4, L4-5, L5-S1. We're going to start with L3-4. Shot. Has some pretty bad scoliosis here. Listhesis. Shot. AP. You can see the lateral listhesis. The first step here is going to be to access each of the discs with a needle. Once we've accessed the disc, there's things we want to do. We want to do a discogram, and we're going to want to get into the disc through the tear, through the herniation. Shot. How's he doing? Shot. His anatomy makes it a bit more difficult. Shot. Feel free to ask questions. All right, AP. We're doing a bilateral 3-4, bilateral 4-5, right 5-1. All right. Yep, back to a lateral. It's interesting. Shot. Shot. AP. So I'm right at the back of the disc. Go ahead, lateral. It's interesting. I'm at the back of the disc on the AP view, but not the lateral view. So I'm going to have to go a little more lateral. Shot. Shot. AP. Hopefully this is going to fix. But the navigation to the back of the disc where the tear and herniation are is the first part of the surgery. It looks good. That looks a lot better. I'm happy with that. All right. Shot. Okay. Feel free to ask questions during the surgery.
We have a question. This comes from Barb on YouTube. They asked, where are you located?
Deuk Spine Institute is located in Florida, United States. Shot. We're located on the Space Coast currently. We're opening an office in Orlando next year, but right now we're located near NASA, right in Florida, right on the east coast of Florida. We take patients from all over the world. Shot. This patient, for example, is from Ohio. Shot. AP. So he's traveled here to Deuk Spine excuse me, because he has basically back pain coming from 3 discs, L3, 4, 4, 5, 5, 1. He did not want a fusion done. That's what was offered to him. We feel we can fix the problem without fusion shot by going in and basically cleaning up the tear in the back of his disc shot. It's something we do all the time, and it works very well. I could feel the herniation shot. There's a large herniation here. All right. Knife. We felt that we could do this surgery safely, even though he's got this deformity of his spine where it's twisting and slipping. And I've done a lot of these patients with slips and twists. Other doctors may say you need a fusion, but fusions are far more aggressive and dangerous. There's a lot of risk with fusion shot. Fusions have complications that are very serious many times, and patients don't want to take that risk. Shot. They would rather have a less invasive procedure that is less risk, less bleeding, less scarring, less chance of complication. And that's what this surgery offers them. We don't fuse bones. We just go in and repair the disc that's injured. You see there's a tear in his disc here, and that tear is what's causing his back pain. And some other doctors may tell you, well, you're going to have to have a fusion done because you have instability. But instability is not defined as slippage. Instability is defined as pain that's excessive or a neurological deficit that occurs with a normal physiological loading of the spine. That was the original definition by White and Punjabi many years ago. Shot? AP? So to stabilize the spine, you have to eliminate pain and neurological deficit. And we're able to do that with the Deuk laser disc repair without actually doing major open back surgery. We've been able to do it in 1,700 patients. So this patient traveled here for this minor, minimally invasive procedure. I think it's going to work. We just got to, first of all, get into the discs, though, and so that we can fix them. Shot? And it's not easy because he has slippages, and he has big herniations, and he has deformity, AP, so far we're doing good. We've gotten the needles in both sides at 3-4, the disc at L3-4, the disc at L4-5. We have one more to access, that's the L5-S1. It's going to be very difficult to do on the right side. He's had prior surgery? No?
He had laser surgery with the spine institute.
Yeah. He went to the Laser Spine Institute at some point. So, all right. We have one more to go, the L5-S1. Before I start, I want to make sure the x-ray is perfectly lined up. Looks like we're off a little on WAG. That's better. You can see the pedicles overlining themselves at L5. All right. I don't know if I can, I don't know if I can get to the 5-1 disc through the same incision, but I'll try. Any questions so far?
Yes, we have a comment and a question, but the question, it comes from Barb on YouTube.
Hi, Barb. Welcome.
They asked, do you work with degenerative disc disease?
Yes, Barb, we do. As a matter of fact, almost all of our patients have degenerative disc disease, almost 98%. So yes, we can eliminate the pain from degenerative disc disease with this procedure. We don't need to do the invasive open surgery. This is a much safer alternative than invasive open surgery. AP? Degenerative disc disease is essentially the same condition we're treating here. It's just more advanced. There are more structural changes. You have collapse of the disc. You have end plate changes where the bone becomes irregular, abnormal, shaped, shut. How is he? Is he almost with us completely?
How you doing, my friend? You okay?
I'll need him awake before I go
Okay.
any further.
How are
Let's
you?
go AP.
You okay? We're gonna ask you some questions now, all right? You're doing great.
Let me know if he's fully cooperative.
Are you with us? He said, oh yeah.
All right. Are you having any pain?
You having any discomfort or pain right now, sir? Look.
Huh?
Where's the needle at, sir?
Just not down your leg?
Any pain down your leg, sir? No.
All right. So basically the first step of the surgery is to place these needles through the holes that are already there in the spine. The only damage we're doing to his entire body this whole surgery is that cut right there. All the other spine surgeries that are more invasive, they make a huge cut, they damage the muscle and tissues underneath the skin, they cause scar tissue and bleeding and pain and suffering, and then they drill holes in the back of the spine. Okay, that's what the Laser Spine Institute did. And we do this surgery without destroying any of the natural parts of the spine. That's one of the things that people like about it. Because of that, patients don't need powerful painkillers. Are you comfortable? Don't move.
Don't move.
Just answer me.
When you ask a question, don't move your head, okay? Keep your head still.
Are you having any pain?
No.
Nothing? Let me know if you do. So as I'm navigating down to this 5-1 disc, it's very hard to get to. I want to make sure I'm not too close to the nerve root. If I am, he'll tell me. He'll say, ow, pain in my leg. So I'm looking for that. No pain in your leg?
No pain, he said.
All right. So he's had back pain for how long now?
3 years.
Huh?
3 years. It's mostly been leg pain.
It's been longer than 3 years because he's already had surgery. When did your problems with your back start?
How many years ago?
When did your back pain start?
When did your back problems start?
2010?
2018.
All right. Well, he's saying 4 years, so we'll just put 4 years. Let's go ahead and get ready to show our video on how do herniated discs cause back pain and also leg symptoms. All right, welcome back. So you can see now that the whole basis of back pain and neck pain is inflammation in the back of the disc, in the posterior annular tear. And leg symptoms come from bulging discs that bulge out through those tears and pinch on the nerves or irritate the nerves. That's really his main complaint. Are you comfy?
You comfortable, sir? He said yes.
All right, we're going to put you to sleep in a minute. I just need your help for a minute, okay? How bad is that on a scale of 1 to 10?
Give us a number.
How high does it go?
What number?
How high did it go?
5 or 6.
Is that where you get your pain typically?
Is that where your pain is located?
Is that where you get your pain? When you get it? Okay, good.
Yes. he
Thank
said
you.
yes.
All right, so that was 3/4 is 6/10, concordant. We're just doing what's called a discogram. I'm injecting some dye into his discs. How bad is that on a scale of 1 to 10? 10 being the worst pain.
Give us a number.
What's the highest it goes?
7.
Did you say 7 or 10?
7.
All right. Is that where you get pain? All right.
Perfect.
So that's 7/10 concordant at 4/5. Good. We're almost going to put you to sleep. We just have one more to test. All right. He's doing great. How bad is that on a scale of 1 to 10?
8.
8, 6, 7, 8. He's going up. Is that where you get your back pain when you get it? That's all going to be gone when you wake up. You get to go to sleep.
Nika, you ready?
I want you to count from 1 to 100 out loud for me in Turkish. I'm just kidding. I would never make you do that. Count for me in Armenian. All right, so take a look here, Henry, at this x-ray. Jordan will show you. Show us at 5/1 the dye leaking out in the epidural space. Yeah, you can see that big, dark is all dye that we injected. It leaked out through the tear in the back of the disc at 5/1. And you can see it going down the nerve root. Nope, to the right. Yes, there. That's the L5 nerve root. Apologize for my coughing. I had sinus surgery myself on Friday, 4 days ago, and it's still have a lot of swelling and drainage. All right, shot, we're going to get started. So we've already done our discogram. We've accessed the disc. We've done our discogram. Next is going to be doing the Deuk laser disc repair. Shot, let's show our audience how the Deuk laser disc repair works. Num num. Welcome back. You understand now from the video animation how the Deuk laser disc repair works. We go inside the disc through a hole in the natural opening in the side of the spine. We don't make any holes like other surgeons make holes. And we get in here and we clean out the herniation and the tear so that the disc will heal naturally. Shot? surgery is less invasive than open surgery, and it's better for the patient because you're not damaging any of their muscles or joints or ligaments like a microdiscectomy will. And the amount of pain you eliminate from the disc is almost 100%.
Thank you.
Anyway, see if your brother could find a company called Lumenis. Lumenis, right?
Yeah.
They're Israeli.
Luminous in Israel.
Lumenis.
I'll definitely keep that noted for sure.
If he can find them there and we can purchase, I want to purchase something from them.
I'm sorry.
You guys need to scope this on.
Make sure it's connected to the wall, Jordan, please.
We don't have the feed for the scope. All right. Well, I know you guys can't see this yet, but
Sam, can you turn on the light here, please?
I'm sorry?
Turn on the light here. Oh, no, leave it like that. Leave it like that. No worries. Leave it like that.
there we go. All right. So far, so good. Our patient is sleeping
We can see now.
comfortably, and we are moving on to do our first Deuk laser disc repair. As you saw in the video, we use a laser. This laser fiber is 1 millimeter.
We have a comment
Sure.
from W on YouTube.
Yes, we welcome comments.
They said, I am a veteran diagnosed with MODS to severe spinal stenosis. When I walk, my legs get numb.
Yes.
When I sit, it elevates the pain, and I too don't want the spinal fusion. I am currently being treated at a VA hospital.
Yes. Thank you for commenting. You have what we call neurogenic claudication. It comes from spinal stenosis. It's very easy to fix with this surgery right here. This is the best surgery in the world for your problem. Unfortunately, the VA doesn't want you vets having access to the best care yet, because they know that if this surgery was available to veterans, all the veterans would get it. So they like the fact that you can only have a fusion because they know you won't get it done. That saves them money in the end. Anytime patients refuse treatment, it's always good for the insurance companies. And yes, the VA is an insurance company. I worked at the VA hospital for many years, 7 years actually. And I know how they work. They're all about rationing, saving money, not spending on the vets, restricting schedules, cutting clinics short, understaffing so that not enough patients can be seen. I could see 50 patients a day here, but at the VA hospital we're only allowed to see 7 in the morning, 7 in the afternoon. We tried to get more on the schedule, but they wouldn't allow us to expand the VA schedule. They said they don't want more patients treated, basically. So you're part of a broken system, my friend. But if you do decide that you want to get fixed properly, you come to Deuk Spine, and we can do that for you. We can't fix the political system. We can't fix the VA hospital. We can't fix the economics of healthcare, but we can fix people's backs. And we don't do cosmetic spine surgery. That's a famous quote from a very intelligent anesthesiologist that I know. We don't do cosmetic spine surgery. I love that. That's literally genius. All right. So far, everything is going well. We are in the left L4-5 foramen. This is the tear where the herniation has come from at L4-5 on the left side. This is all herniated disc, scarred up. See the gold color that I'm zapping with the laser? This white stuff is scar tissue and herniation stuck together within the annular tear. Now you notice the grabbers do nothing. They're useless. Grabbers are the standard instruments of spine surgeons. That's what other spine surgeons would use, are grabbers. So unfortunately, grabbers are useless by themselves in disc surgery because there's so much scar tissue, all this white stuff. You can go in there and grab, but it doesn't come. It doesn't come out. It just stays there. So you get nothing done if you just use grabbers. If we didn't have the laser, we'd be in trouble.
We have another question.
Sure.
This comes from Big John on YouTube.
Hello, Big John.
And they ask, people with cervical spine issues, I understand having arm weakness, but could they also have leg, walking, or gait issues as well from a cervical spine issues? If so, can you explain the connections for this?
Yeah, sure. Absolutely. The cervical spine has the spinal cord. The spinal cord connects your brain up top to your legs. Anything damaging the spinal cord in the neck could cause trouble with balance, like balance difficulty, instability. I don't feel steady on my feet. I'm dragging my feet. But you'd have to have pretty significant compression of the spinal cord in the neck. It wouldn't happen with mild compression. That's why you need an experienced neurosurgeon to tell you if your leg symptoms are from your cervical spine or not. A lot of surgeons can't even tell you because they don't know. But an experienced neurosurgeon like those at Deuk Spine would be able to tell you. But that's why, because there's a connection between the legs through the spinal cord in the neck traveling down to your legs. That's how you walk. Your leg muscles are activated by nerves controlled by your brain with impulses passing through the spinal cord, which is in your neck. Also, your ability to feel your bladder and bowel, that passes through your cervical spine as well. Right? All the signals from your bladder and bowel pass through your neck. That's why people with spinal cord injuries in their neck can't move their legs. They can't walk. They can't control their bowel and bladder. They pee on themselves. They poo on themselves. They can't walk. They're bedridden. They're paralyzed. So a disc herniation or degeneration with associated stenosis in the cervical spine can definitely affect the legs. Doesn't mean it will. I don't see it very often. It's very rare, actually. So, get a second opinion. Deuk Spine Institute offers a free MRI review. You can get answers, honest answers. Great questions so far. This is all scar tissue with herniated disc stuck in it, the white stuff. What color is a normal nucleus that it becomes herniated? It's white. Why does it stain blue with our blue stain? Because it's degenerated. Will the nucleus stain blue when it's covered with scar tissue? No. No matter how degenerated it is, it won't stain blue. You have to have free fragments of nuclear herniation to stain blue. Anything that's scarred up will not stain blue. It'll stay white like this. Grabber. Great questions. Feel free to ask more questions if you want. Almost done. I'm right here at the outside of the disc. This is what was pushing on his nerves, by the way, all this stuff, causing his leg symptoms. Same as the veteran that made a comment earlier, leg symptoms. It's all due to this stuff right here. Herniation and scar tissue. Creates a mass. It creates a tumor, which is a mass. A physical, hard, swollen area that's enlarged. That enlargement pushes on the nerves, causes leg symptoms. Weakness in the legs, numbness in the legs. Even pain going down the leg called sciatica.
We have another question.
Uh-huh.
This comes from Big John once more on YouTube.
Sure.
They asked, excuse me, if there is a bone spur and or herniation that is pushing against the nerve root, when you are using the laser on the bone spur, what prevents the laser from damaging the nerve root or even creating a hole in the nerve root or spinal cord causing a leak or even damaging the nerve root or spinal cord?
Well, it's the same thing, John, that keeps a surgeon from taking a metal scalpel or a metal probe and damaging the spinal cord or the nerve root or making a hole. It's called control. The surgeon has to control their instruments. Any surgeon can damage any part of your body, nerves or blood vessels or organs, if they don't control where their instruments are. And you can see I'm controlling the laser. I'm moving the laser up and down, left and right, in and out. That's all me controlling. Same thing with metal instruments. Surgeons can do far more damage with metal instruments than they can with a laser. A laser, you're not going to kill anybody. You might hurt something, cause a little discomfort. But with metal instruments, you can kill patients. So it's more important the surgeons control the metal instruments that they use in surgery than a laser that's super small, very precise. But that's the answer, control. And control comes down to being able to visualize your target and the surrounding tissues, making sure that you're targeting your target only and not causing any damage elsewhere. That's the problem with open surgery like discectomy, fusion, is you're causing damage to all these other tissues that are around the spine or the spine itself. But with the laser surgery you're watching, we don't do any damage. It's the safest, least damaging surgery in the world that fixes problems. That's why our results are so good. That's why we have so many satisfied patients, that we have testimonials. Hundreds upon hundreds of testimonials. Control. You can't just go to high school and start doing spine surgery. You have to go through extensive training that teaches you what to do, how to do it. It's called residency and fellowship and internship. And those years and years of doing the surgeries, you learn how to do them properly with control. So you avoid injuring patients. Anybody could come and do the surgery, but they're going to end up hurting the patient. So it's the training that I have that allows me to do the surgery safely, properly, precisely, without damaging things. That's something a lot of the public doesn't understand, is how much training we go through. It's not 1 hour, 2 hours. It's quite literally 7 years times 52 weeks. How many hours is that? 7 years. Let's do 7 times 52 times 110. What number is that? Henry? Berndes?
I'm not great at math. We do have another question, though.
Uh-huh.
This comes from Big John once more on YouTube.
Well, we need an answer on the hours.
On the hours is
I told you how to calculate it. It's easy. It's 7 times 52 times 110.
40,040.
All right, so 40,000 hours of training. So when you do 40,000 hours of neurosurgical training, like I did after medical school, then you can do these surgeries and control your instruments properly. The same applies for any specialty, by the way. Even the anesthesiologist, he can put those tubes in, IVs in, better than I can. Why? Because he's had a lot more training. And he's capable. Comes down to training and it comes down to competence. Not everybody can learn it.
We have about 25,000.
You guys have 25,000? Really? I'm surprised it's that much. Isn't it 3 years?
Yeah, it's 3 years plus the internship you do 4.
Oh, is it 4 years? All right, we're pretty much done here. Let's see. Maybe right there, just right there, Luis. For anesthesia?
Yeah.
Great. Well, he's trying to increase the cost of healthcare even higher? Nobody can pay anesthesiologists already. The insurance companies pay you guys $80 an hour. But there's no single anesthesiologist that will work for 80 bucks an hour. You know? So how are they going to add another year of training and pay you guys so little? The answer is they can't. They want you paid a little so that, well, you're going to have to get money from the hospitals, from their facility fees, which are supposed to be facility fees, not professional fees. It's a totally fucked up system. They're basically trying to raise the cost of surgery for all the people that provide it. I need more irrigation. I need a longer needle. Where is the long needle? You got to be careful. She almost hit the sterile part of that scope. Hey, look, stop. Do you see how close you came to the sterile part of the scope? What?
I thought I had more space than I did.
No, your head basically came an inch away from that sterile. What are you supposed to be?
Getting here.
That's not the right answer. What are you supposed to be? How far away from a sterile field are you supposed to be if you're not sterile? No, 12 inches if you're experienced. Okay, you came within 1 inch of that sterile drape. It may not matter to you, but it matters to the patient when they get an infection. And then they need 6 months of IV antibiotics. Jordan, it's your responsibility to watch that fluoro. Make sure people don't get too close to it. Is that understood?
Yes, sir.
You guys all need to do your part. I shouldn't be sitting here monitoring how close people come to a sterile field. I need to focus on the surgery.
No, no, you put some.
Yeah, you see the problem? I'm not focusing on the surgery. I'm focusing on this other shit that you guys should be focusing on. Let's change the drape.
Can I snap that right there? Open the door, let's get her all the way to the right side in the corner, please. Thank you.
Go do something else. I've got this. All right, any other questions at this time?
Yes, this next question comes from Big John, once more on YouTube. They asked, can you share your thoughts on why anterior is better over a posterior approach?
That makes no sense, John. And why anterior better than posterior for what?
Cervical spine, they said.
Yeah, the reason anterior is better is because the problem is anterior. It's not posterior. The problem in the cervical spine is a herniation, which is anterior. It's not posterior. So people that go posterior are not fixing the problem. They're indirectly trying to deal with a problem that doesn't work by indirectly dealing with it. That's why. He's responding. Shot. Shot. All right. AP. Let's just do a quick AP. He looks like you're off a little on orbit. Quick AP. Shot. Don't move it around so much. There we go. Lateral. That looks perfect. Let me know when you're ready, Dr. Bernes. Seems to be okay. Shot. Take that. Shot. All right, let's get the scope on. So we're now at 3-4 left side. We're going to do the right side 3-4, 4-5, 5-1 next. A lot of scar tissue here. This is what's pushing on his nerves. All this scar tissue, which wasn't there many years ago, it's grown. Did you have a question?
Yes, we have a question from Dr. Shumayu on YouTube.
Dr. Shumayu, welcome to our live stream.
They ask, is this patient undergoing this procedure for back pain or leg pain?
Both. Yeah, this procedure you're watching fixes back pain and leg pain. The patient's chief complaint is leg symptoms. And people rarely complain about leg pain. They complain about leg weakness, discomfort, burning, aching, cramping, typical what we call neurogenic claudication type symptoms. He has neurogenic claudication type symptoms. There's a piece of herniation right there. Look at how it's vascularized. Do you guys see that? That piece of herniation is getting blood vessels on it. That's what you're seeing right there.
We see it, yes.
Yeah. It's called vascularized from the amount of inflammation. Remember, this is an inflammatory disease. The back pain is from inflammation of the back of the disc. The leg pain is from inflammation. The weakness, numbness, and tingling people get in their legs or neurogenic claudication is typically from compression of the nerves. So it's not due to inflammation, but inflammation contributes to neurogenic symptoms because inflammation creates scar tissue. Scar tissue presses on the nerves and causes this radiculopathy, we call it, which is a dysfunction of the nerve roots or nerves. So his chief complaint is his legs, but a lot of our patients have surgery for back pain. Now his back pain from his discs will be gone, but that wasn't the main reason he came. The main reason he came was his neurogenic claudication. Great question, doctor. Thanks for asking. All right. Pretty much outside the disc, a little bit of epidural bleeding, no big deal, some scar tissue. Sorry for the poor visibility. Just about done. By the way, the bleeding we're seeing comes from his prior surgeries where he had laminectomy and discectomies done, and those surgeries cause a lot of scar tissue to form. Got it? And that's what we're seeing is the bleeding from that scar tissue from his prior surgeries. Nothing I can do to prevent that, and we don't need to. It's not really the issue here. It's just something I'm making note of to you so you guys are aware of it. These are all little pieces of herniation. Again, this is the, what do we say this was? L3-4 or L4-5? L3-4. All right. Looking good. Take that. Let me see. Could get a little more there in the upper foramen, just under the nerve root. There's another piece. Any other questions?
No current questions.
All right. That's it here. We're going to move to the other side, which is the patient's right side. Next. Scope off. Take. Doing a little irrigation, a little betadine. We used to use bacitracin, but in the United States that's fallen out of favor. I guess some of these doctors were injecting it in the muscles too much, causing some type of neuropathy and nerve damage and muscle damage. Not us. We never did. But I guess some doctors were injecting bacitracin in the muscles and causing problems for the patient. So they took the bacitracin off the market. We had been using it for, 25 years, 30 years, maybe longer. You know, at the end of our surgeries, we would irrigate the wounds. Come on in. And because we didn't have access to the bacitracin to irrigate the wounds anymore, we switched over to betadine. Some surgeons just don't do anything. But I don't think that's wise. I mean, if you're doing surgery, especially on someone's spine, you don't want them getting an infection. You want to do everything you can to reduce the chances of that as low as possible. Of course, we do everything sterilely, but we give antibiotics IV, we do sterile prep and drape, we also use sterile irrigation. I'm going to start here. So that's why we do that. All right, now we're on the right side. Shot. Okay, looks good. You can see the guide wire. Taking out the needle. Num. Any other questions?
Yes, we have a couple questions.
Sure.
This first one comes from Dr. Shamaya, once more on YouTube.
Where is Dr. Shamaya from?
Doesn't say at the moment, but I'm sure they're listening and they'll reply in a moment. But for right now, their question is, I noticed a L4-5 generative spondylolisthesis on the x-ray.
Yeah.
Do you think the dynamic instability is also contributing to the leg pain, or is it just the stenosis?
That's a great question. So in my opinion, I don't think there's any dynamic instability contributing to the leg symptoms. And that's based on treating over 500 of these grade 1 or grade 2 spondylolisthesis with back and leg symptoms over the last 17 years. And every single patient, their leg symptoms go away. Their strength improves, their numbness eventually goes away, their neurogenic symptoms go away almost immediately. So what that taught me is that this listhesis is not important. It's just a radiographic finding. And we made way too much of listhesis. As a matter of fact, you know this because if you read the literature out there, half of the doctors that do spine surgery are in favor of fusing a spondylolisthesis. The other half are against it. And they show that the results are equivocal, whether you fuse or you don't. So that supports the fact that the listhesis is not clinically significant. Now, if I were to do a laminectomy, if I were to go back there and do an open surgery to decompress the nerves like I used to do for many years, where I do a Smith-Peterson osteotomy, wide decompression, then I would definitely do a fusion of the listhesis for sure. I used to do those all the time. But given the fact we're not removing any of the posterior elements or ligaments or tendons, muscle, we're going through the foramen, I don't see any reason. We're not creating any instability with the surgery. So there's no iatrogenic instability created with my procedure. Whereas if I did an open surgery, I'd be creating iatrogenic instability, surgeon-generated instability. So the answer is no. I don't feel it's necessary to treat it, and I don't feel it's contributing. And that's based on, again, results, not just theory, but real results. It's just that I've had a lot of patients over the years who said, I don't care. I don't care if I have a listhesis. Try the laser. If it works, great. If it doesn't work, then we could always do fusion later. And I said, okay. So I did the surgery for them, the laser surgery, and lo and behold, their pain went away. Their symptoms in their legs went away. And I was surprised, to be honest, for the first 10 of them. But then once you got to about 100, you realize it's pretty consistent finding, you know, pretty consistent outcome, and that there's no reason to do fusion or anything else with the listhesis. So leave it alone. Now, I wouldn't treat a grade 3 or grade 4 with this procedure. I think it's reasonable to do a grade 1 or grade 2. At least that's the experience I've had. I don't see too many grade 3s, very rare. But if I have a grade 3, I'll tell them they need a fusion. That's just the way I practice. It's a great question. Very good question.
And to answer where Dr. Shemaev is from, they said that I am a spine surgeon from India. I perform endoscopic transforaminal disc debridement for patients with early discitis. The back pain settles immediately. Do you have any insights on why?
Yes, I'm the one who discovered that. Of course, it's because inflammation is the cause of the back pain. And if you debride the disc and you get rid of the herniation, you get rid of the source of inflammation. We've been teaching that now for 17 years. But I'm glad you understand it. You're much farther ahead of your colleagues than most other spine surgeons, because most spine surgeons don't understand the inflammatory nature of back pain, or neck pain for that matter. All right, we're at the back of the annular tear where the inflammation comes from that we've been discussing. And we're just about, got some more herniation here, you can see it. And it's stuck. There it is, there's a nice piece coming up, right, through the endoscope. A lot of people think herniations are single events. They're actually multiple events. The average herniation is around 20 pieces to 30 pieces. So that means that patient has had 20 to 30 herniations in their lifetime before I get to them. And each herniation makes more symptoms, which is why you hear from people with herniated discs that, oh, I got better for a little while and then I got bad again. Pain came back. It's coming back because you keep reherniating. The reason people reherniate is because there's a tear in the back of the disc where the herniation comes out of. It's called the annular tear. And until you do the Deuk laser disc repair, which is the surgery where we debride the tear that Dr. Shemaev is talking about, he does the Deuk laser disc repair. He doesn't even realize he's been doing my procedure. And that's okay. I'm not asking for credit, but you should recognize the pioneer who discovers it and credit them. But that's exactly what's happening. By debriding the tear, you allow the disc to heal naturally. And when the disc heals naturally, there's no more tear, there's no more herniation. All right, I apologize for the poor visibility, but it's due to some bleeding. Not a lot of bleeding, very little.
We have a couple questions.
Yeah, you can see some bone spurs there on the end plate. And I want to make sure this is not a big piece of herniation. Remember, when I push my dilator into the disc, I'm literally pushing pieces of herniation back into the disc, and then we're extracting it from the inside out. And that was a technique taught to me by Dr. Anthony Young, one of my mentors. It's called the inside out technique. And he always said it's the safest way to remove the herniation. The other way of doing it is called the outside in, where you start in the foramen and remove the herniation from the foramen. I don't think that's the right way to do it, but there are doctors that do an outside in technique as well. I don't. Go ahead.
These next two questions come from Lioness Blessings on YouTube.
Linus Blessings?
Yeah, Lioness Blessings.
Lioness Blessings, excellent. Welcome. Welcome to our live stream.
First question is, greetings. Will having steroid injections cause problems for this type of surgery to the lumbar spine?
No, No, steroid injections, as long as they're done properly, would not preclude you from having the surgery or cause problems. The problem with steroid injections is they don't give any kind of permanent solution to either back pain or radiculopathy. It's temporary at best. And in many patients, it doesn't work at all. I like to use steroid injections in patients that, they can't have surgery right now and they need it. They can't have it. They're symptomatic from inflammation, pain, and they have to wait a few months because they're traveling or they have obligations in life. They're not able to have their surgery yet, so you give them a steroid injection and they feel better for a few months. So it will not affect their ability to have this surgery. But steroid injections never fix anything, okay? They're always temporary, and what a lot of people don't realize is they do have complications. Steroids are powerful, biologically active substances. They turn on a lot of our machinery in our cells, in our bodies. They have a lot of effects throughout the body. One of them is weight gain, blood pressure increase, and sugar increase. Your blood sugar will go up with steroids. So just be aware of those side effects, okay? Great question.
This next question comes from Lioness Blessings, once more on YouTube, asking, what would the difference in surgery be if there is a cyst associated with a bulging disc, L5 to S1?
That's a great question. The cysts that you're talking about, if, I don't know what kind of cyst specifically, but there's typically, let's just say 3 types of cysts. They're benign cysts and there are seriously malignant cysts. And of the benign cysts, which are by far the most common, the most common cyst down there is going to be a Tarlov cyst, which is just an arachnoid cyst. There's really nothing you need to do. It doesn't affect the surgery at all. The second most common cyst over there is going to be something called a synovial cyst. Now, synovial cysts are different. They're actually can put pressure on the nerve, and they can affect your results in a bad way. So it depends on what kind of cyst you have, a Tarlov cyst, T-A-R-L-O-V cyst, or a synovial cyst. But if it's a synovial cyst, then that comes out of the facet joint, and you have to have surgery to open up that and get rid of that cyst. And I would recommend a laminectomy, discectomy for that procedure. The laser surgery would not work. The one that I'm doing right now would not work. And I have had patients like that where I told them, listen, you've got a synovial cyst. It's not common. You don't see them often. But you've got a synovial cyst, and I don't think this surgery will work for you, and I don't recommend it. I recommend an open surgery. That's one of the few cases where the open surgery is definitely better. Good question. I just don't know what kind of cyst you have. All right, just about done. Apologize for the poor visibility. Sometimes that's just how it is. You can still see the laser, and I can still see what I'm doing. Looks good. I may want to get a little bit more there. Any other questions?
Yes, we have a couple more questions. This next one comes from Jerome on Facebook.
Hello, Jerome.
They asked, do you find the IVF can open with degenerative listhesis? However, the lateral recess can narrow?
Yes. Yes, absolutely. Great question. So what you're asking about is, can the intervertebral foramen be open, but the lateral recess be narrow? The answer is yes. As a matter of fact, what most people don't understand is that lateral recess stenosis, or narrowing, is the most common cause of symptomatic radiculopathy. It's not central stenosis. It's not even foraminal stenosis. It's lateral recess stenosis. And just for those of you who don't know what the lateral recess is, it is quite literally the space underneath the facet joint that is medial to the pedicle. So if you go to the space between the pedicles above and below, that's called the foramen, neuroforamen. But if you go a little more medial to that, just medial to the medial border of the pedicle, but lateral to the paracentral zone, now let me have a little more irrigation. Then you have what's called a lateral recess. The lateral recess is the most common place to have symptomatic stenosis causing leg symptoms. Okay, and we're able to decompress that with this surgery. This surgery you're watching right now is the best surgery in the world, transforaminal endoscopic surgery for decompressing the neuroforamen and decompressing the lateral recess. It's not good for central stenosis, but central stenosis is rare. You don't see much central stenosis because patients don't complain about it. But this is literally the best surgery in the world for 95% of stenosis. Even extraforaminal stenosis. You know, if you have a far lateral herniation in the foramen, this is the best treatment. So this surgery is the best treatment for foraminal stenosis, extraforaminal stenosis, and lateral recess stenosis, and paracentral herniations. Basically, 98% of symptomatic stenosis can be treated with this. You can't treat stenosis from a synovial cyst. Okay, that's one thing you cannot do. That's why I don't recommend it for synovial cyst surgery. Shot? But synovial cysts are rare, very rare, rarely symptomatic, rarely large enough to be symptomatic, so it's not really a consideration most of the time. The vast majority of our patients have lateral recess or foraminal stenosis. Shot? Great questions. All right, we're heading down to the L4-5. For those of you who could see the slippage, it's called a grade 1 slip. It's almost 25%, almost at a grade 2. I've done grade 1 and grade 2 slips. I've even done grade 2, almost 3 slips with this technique. And I had no residual leg symptoms, no residual back pain, not a single patient. I've never had to convert one of these to a fusion. And I don't expect to have to start today. All right, huge tear. I could feel the dilator passing through the tear easily with zero resistance almost. There's a big tear back here and a big herniation. Any other questions?
Yes, this next question comes from Dr. Shimayu, once more on YouTube.
Uh-huh.
And they asked, do you believe in basivertebral nerve ablation for patients with back pain and scans showing modic 1 or 2 end plate changes, or can this work for them too?
You know, it's a great question, doctor. I don't know enough about the basivertebral nerve ablation. I've seen patients that have had it done over the years here in the States, and it doesn't work. But maybe there is some way to make it work properly. I don't have the experience with it. And I don't think basivertebral nerve ablation is an appropriate treatment for somebody with radiculopathy. So almost all my patients have radiculopathy along with back pain. So I'm not just treating, discogenic back pain, I'm treating radicular symptoms. And so I think the best way to treat these people is by treating their tear and herniations. That's what I believe, based on my experience. That's the most successful treatment. There's an old saying we have in the United States. If it ain't broke, don't fix it. If it's working really well, there's no reason to change what you're doing. I don't see how results could be any better than what we're doing. Maybe I'm old-fashioned or wrong, but that's been my experience.
We have another question.
Uh-huh.
This comes from Big John on YouTube.
Sure.
And they asked, what kind of sedation do you use? Is it like a colonoscopy or a local and or epidural anesthesia or a heavier form of sedation?
That's a great question. What we use is the same thing we've been using for the last 17 years for lumbar and thoracic. It's propofol sedation with MAC, monitored anesthetic care. Okay, so we have the patient prone, their IV sedation with propofol, and get a little bit of fentanyl when they're in pain. They get some Versed so that they don't remember the surgery, and sometimes Dr. Berndes will throw in a few more ingredients. I'm just kidding. And then just airway support. So we've been doing it this way for 17 years, and we've had great results. So the patients are not intubated. They have no tube down their throat unless they're cervical. Yeah, well, that's our little secret. Yeah. So, and with that type of anesthesia, you're going to have some patients that respond very well to it and some that don't. The ones that don't are the ones who consume a lot of alcohol or THC, marijuana, or other types of drugs like opiates, and other drugs, right, doctor? Marijuana is the worst, he says, Dr. Berndes says. Patients that are taking medical marijuana for their pain are the hardest for us to control with this sedation technique. They just don't tolerate it that well.
Before it was legalized, you never noticed it that much.
He said we didn't have that much problem before it was legalized. Now that medical marijuana is legal in the United States. Huh?
It's much more potent.
Much more potent? It's really? Medical marijuana is more potent?
More accessible.
I didn't know that.
Street marijuana was cut with oregano and had all these herbs in it and stuff. That's why they called it weed. But on the street, it was cut with everything. But medical marijuana stuff is pure high-grade THC.
Dr. Berndes says the medical marijuana now is so powerful with THC that it really affects the physiology of the patients receiving this sedation, and it makes it much more difficult for us to do the sedation, though we're still able to do it.
You just have to triple the dose of propofol used sometimes.
He says we have to use about 3 times as much propofol when people are on medical marijuana because their bodies just soak it up.
Ideally, we like them to be off of it for a couple of weeks.
Yeah, we would prefer our patients to be off of any medical marijuana for a few weeks before they have surgery. All right, we're just about done with this disc. I'm working my way, again, inside out technique that I learned from Dr. Anthony Young. I think Dr. Young was trained by Dr. Parvis Camden, who was the pioneer of transforaminal surgery in the lumbar spine. Dr. Camden was an orthopedic faculty surgeon in Pittsburgh. Thanks. And Dr. Camden taught residents in orthopedic surgery this endoscopic transforaminal approach back in the late 80s, early 90s. And Dr. Anthony Young was one of his students that trained with him. And Dr. Young taught me my lumbar surgery, along with a few other surgeons, like Dr. Sebastian Reuten, Dr. Seng-Ho Lee, Dr. Gun Choi, some of the early pioneers in lumbar endoscopic transforaminal. The Koreans, as I've said before, were the ones who taught me cervical. Cervical endoscopic surgery, anterior approach, along with Dr. Reuten, Sebastian Reuten. Dr. Young did not do endoscopic cervical. All right. All of this is part of the herniation and scar tissue associated with it. I want to debulk it. It's like a tumor, benign tumor, made out of inflammatory tissue. And it's pushing on his nerves. And that's where his leg symptoms come from. The reason is, of course, because his prior surgeries, he never had the actual disc repaired. He had surgery at the Laser Spine Institute. And the Laser Spine Institute, they're out of business now, but they did basically a microdiscectomy. Microdiscectomy is a destructive surgery. I don't advocate or recommend it to anybody, unless you have a synovial cyst. But the Laser Spine Institute did his prior surgery, and they basically left the annular tear and the herniation there. They did a laminectomy, laminotomy, foraminotomy, partial facetectomy, but they didn't treat the actual source of his problem, like we are now, which is the herniated disc. Annular tear. All right, just about done. You can see the epidural space at 12 o'clock. You can see the blood vessels. You can see the last of the herniation there at 12, looking lateral. A lot of the younger surgeons don't know to look lateral, but there is a lot of lateral herniation. You have to make sure you get it. You have to be careful not to get too far lateral, because you can affect the exiting route. Any other questions?
Yes, we have a couple questions. This next one comes from Jerome once more on Facebook. And they ask, generally, thank the doc for doing these live streams. It is quite amazing. My question is, where did he get his deep desire to fix people?
That's a great question, Jerome. It came from something I was born with. I could tell you that right now. Ever since I was a kid, I would watch people in wheelchairs and crutches, and I always felt so bad for them, like their lives were ruined by their problem. And I always wanted to help them. Even as a kid, like 6, 7-year-old kid, I would just think about them. And when I decided to become a neurosurgeon, I thought I was going to do something like aneurysms or brain tumors. And I just kept gravitating to pain, fixing people's pain and suffering, ending their suffering. I just kept gravitating. And my attendings didn't like it. They wanted me to be, an aneurysm surgeon, or brain tumor, or skull base, or epilepsy. Some, great surgeon, neurosurgeon that fixes tumors and blood vessels. But there were a lot of other neurosurgeons in that field, and there were none that were going into helping people get out of pain. I just was drawn to it my whole life, so that's how I ended up here. And I'm a perfectionist, if you haven't noticed. I like to figure out why things happen, and I like to fix them. And if it doesn't do what I want it to do, I want to fix it. So I just learned over life that if you try hard, you can solve problems, and a lot of times you can make the world a better place. Let me have a laser one more time. By just doing your best to fix things. And sometimes you get lucky and you can find a solution that nobody else found. It's not that I wanted to find a solution nobody else found. Honestly, just wanted an easy life, but as I say to everybody, this is God's plan. I believe that. I think God has a plan for all of us, and this is where God put me. Not what I ever thought I'd be doing. Like I said, I thought I was going to do epilepsy surgery, functional neurosurgery, but here I am. You know, opportunities keep happening. We keep finding more solutions to problems. We now have discovered how to cure hip pain and knee pain and shoulder pain from arthritis without doing a replacement of the joint. It's called the Deuk plasma rhizotomy, and we're going to be rolling that out in 2024 in Florida and the whole world. And basically, I expect joint replacements, knee replacements, hip replacements, shoulder replacements to go away. They're going to go away with this technology. This technology will completely replace them, just like cell phones replaced payphones or digital cameras replaced the old SLR film cameras. It's a no-brainer. It's so much better to do the minimally invasive treatments that we do. Let's bring the floral. One more disc to go. So that's how it all happened, and it just comes back to who I am, you know, as a child, what I was interested in doing, without even knowing how I would do it, or where I would do it, or when I do it. I hope that answers your question. All right, last one, L5-S1. Shot. The blood loss on these surgeries is typically very low. It's around 2 or 3 milliliters, cc's. Just think the average cc is 20 drops. 20 drops. So we typically lose around 40 drops of blood with these surgeries. They're as close to bloodless as you can get. Shot? All right. Let me have that and that. Hold pressure. Any more questions? We're just about finished. This is our last disc. We've fixed 4. We have 1 more to go.
Yes, as of now, we have 2 questions. This first one comes from Bobby on YouTube.
Hi, Bobby.
And they asked, what if slip has par fracture / defects?
Yeah. It's okay if it has pars fractures. Most slips do have pars fractures. What Bobby's asking, folks, is there's a little bone in the back of the spine called the pars interarticularis that connects the superior and inferior facet of a vertebral body, and it keeps the bones from sliding forward. Well, virtually 100% of spondylolisthesis has a pars defect, whether it's a fracture or repetitive fractures. Doesn't matter. It's all the same. The answer is the surgery still works, and the reason is because the slippage and the pars defect are not the cause of the symptoms. They are not. That's because I've done 500 of these patients with slippage and pars defects, and we've never fixed the pars defects, and we've never fixed the slippage. And their symptoms go away almost 100%. So how do you do that? How do the symptoms go away 100%, but we don't fix the slippage and we don't fix the pars defect? The answer is because the pars defect and the slippage aren't the cause of their symptoms. It's obvious. I don't make this stuff up. It just is what it is. If you do the same thing we're doing, you'll get the same results. There's nothing magical about what we do. That's why we put these surgeries online, so everybody can watch the whole thing. There's nothing magical here. It's the same thing. I do it every single time. Right, Berndes? All right. Last disc. I feel like my skirt is falling off. Can somebody grab my skirt and pull it up? Maybe I'm losing weight. It's a good thing. Huh? Well, the floor is very wet. You know, I could take it off, but I don't want it getting on the floor. Oh, yeah. Who is that?
That's Alice working there, trying to help you.
That is better. Just a little bit. Just grab it. I'll move my legs together and lift it. Wiggle it and lift it. Ready? 1, 2, 3. Perfect. Thank you. You didn't know I could do the shake. The shimmy and the shake. Well, I used to dance when I was a kid. We used to do, what was it called? The twist? Sock hops. We would do sock hops. You guys know what a sock hop is? No? You're too young. Sock hop is where, like back in the 40s, 50s, 60s, they used to, kids, there were no cell phones back there, and there were a little bit of movies, but what young adults did for fun is they went to a place and they danced. And they would take their shoes off and they would twist on their socks on the floor. And that's how the whole music and twists and all that came about. These sock hops. Good, clean fun. It's before drugs came, destroyed our country. All right. Any other questions?
Yes, we have 2 more questions. This next one comes from Charlie on YouTube. They ask, what methods do you use to help the patient locate the source of the pain before surgery?
What methods do I use to locate the patient's source of pain before surgery?
Correct.
Well, Charlie, you are exactly right. The patient has to locate the source of pain. Doctors cannot. All we can do is be there to gather information and try to facilitate the delivery of reliable information from the patient, because in the end, the patient must tell me where their pain's coming from. I cannot tell them. And that's one of the biggest mistakes doctors make today, is they go look at the MRI scan and say, oh, you have a bad disc or you have a slippage. That's where your pain's coming from. And they're wrong. Doctors are wrong 99% of the time. The only way you're going to be able to tell where a patient's pain comes from is to ask the patient to point to it. Or you touch their body with your fingers and you say, do you have pain here? And if the patient does, they'll say, yes, my pain comes from there. So I use a combination on the physical exam of the patient. Always I start with the patient, I say to the patient, put your finger on the spot where you have the worst pain. Put your finger and don't move it. Just put it and hold it there and show me where you have your worst pain. So I always start with that because I want to make sure I get the worst pain when I'm treating them. Then I'll say, where else do you have pain? And have them point. Now, you have to be careful because whenever you have pain from a disc or a facet joint or an SI joint, you're going to get a secondary pain, not a primary, but a secondary pain that comes from muscle spasms. And if you pay attention to the muscle spasms, you will get distracted. You will get lost. Muscle spasms you don't fix. You fix the facet pain, you fix the disc pain, the muscle spasms will go away in time after your surgery. So you cannot get distracted by muscle spasms. You're not there to surgically fix muscle spasms. You will never will be able to, unless it's the piriformis, in which case you can. So I start with the patient showing me with their finger, where is your worst pain? I then ask them, do you have pain in other areas? I have them show me. I make note of it, where it's located, and then I do my own touching with my fingers, and I want to find sore spots. Sore spots. What are sore spots? They're tender spots. Why is that important? Because things that are tender on your back include your facet joints, your SI joint, your piriformis muscle, your trochanteric bursa, your iliotibial band, your ischial tuberosity attachment, and those areas, if they're painful and tender, that tells me you have a inflammation within a joint or soft tissue that needs treatment. It helps me identify the source of their pain. So you have to use the patient's hand, and you have to use the physical exam where the doctor touches the different joints and muscles to figure out where the patient's pain comes from. That is the most reliable test in the world. Then I look at the MRI after all that, okay? The MRI will never tell you where pain comes from. MRIs don't talk. And if you have an infection in the spine, if you have a tumor, a cancer of the spine, the MRI will show you, okay? But the vast majority of patients that suffer with chronic back pain do not have tumors. They don't have infections. Of course, in India, you have a lot more spine infections, so those people may actually have an infection. You have to be aware of that. But in the United States, spine infections are rare, except in certain populations, like IV drug users, okay? Diabetics. But in India, it's very common to see tuberculosis of the spine, which would then cause pain, deformity. So you have to be aware of your patient population and what their most likely source of back pain is. In the United States, it's the disc is the #1 cause of chronic back pain. All right, we got 5 minutes left, not even 5 minutes, 2 minutes, and we'll be done. Type up the rest of your questions. I'll come answer them face to face. All right? And so far, the surgery has gone very well. We're pretty much done. I'm just putting the last few touches on the laser annular debridement on our patient from Ohio who's had prior back surgery and at the Laser Spine Institute. How much irrigation you got?
Quarter of a bag.
So you're good. You don't need to switch. This is the last of it right here. That's thick scar tissue, by the way, in case you're wondering. Massive. All that, just whole, it's a whole wall of scar tissue from chronic inflammation. I just want to say great job, everybody. And our next patient is what, a 2-level, 3-level? What do we got? Two. Huh? 2-level bilateral? All right, where is that patient from?
Caribbean.
Caribbean. That's right. I remember now. He's from Grenada. Grenada. Yeah. He's another patient with primarily leg symptoms. Very good. All right. I don't see anything more. Let's see. The nerve root's right there. You guys see the white thing there on the right?
Yes, we do.
That is the nerve root. You see how close it is to the herniation, right? So that's why these herniations cause problems. They irritate or pinch the nerve root. We're done. Great job. I'll come answer your questions, so type them up. That's 5-1, by the way, the hardest to get to. And transforaminally. Great job, everyone. Henry, you want to go to our testimonial?
Yes, sir.
Good morning, I'm Dr. Deuk at the Deuk Spine Institute here in Melbourne, Florida, with one of my patients who traveled from California. He's been suffering with his lower back pain for years and found us on the internet and decided to come here and have the endoscopic Deuk laser disc repair. We performed that 12 hours ago, and here you are, ready to go back to California, it looks like. How do you feel?
I feel great. It took a long time to get to you. Surgery was quick and painless. I don't remember a thing. Your staff was wonderful, but I am pain-free.
That's awesome. Yeah, and you're going to stay pain-free. We don't have you on any pain meds. We don't have you on narcotics, killing your pain. We didn't put any medicine in your back to stop your pain, so what you have is natural. And do you feel that pain anymore that you had before you came here?
No, the pain is completely gone. In fact, I quit taking my own pain pills 2 or 3 days before I got here. And I am on no pain pills at all, and I feel wonderful. When I woke up this morning, it was a different day. And I feel great.
And I feel wonderful for you for doing that. That's why we do what we do. We can cure pain, and we want everyone to know that, because nobody should have to live with pain every day. How does pain affect your life every day?
Pain is traumatic. The kind of back pain that I was suffering put me in bed. And for the last 3 months, I have been absolutely useless. Absolutely useless. And so I found you. It took me a few months to get here, and it was worth the trip.
It will be for the rest of your life.
Absolutely.
Worth the trip. Pain robs us of our dignity, doesn't it?
It does. It absolutely does.
And your parents are here, and they're very supportive. And that, to me, is so important, that you have people that understand what you're going through. I'm sure your parents have been a big support for you.
Oh, absolutely. Yeah, I was at work, a short story. I was at work last Wednesday dealing with this pain, and my back finally gave out to where I literally could not walk anymore. And I was 600 miles from home. And so I called my mother and father. They flew to San Diego and arranged the trip to get here. I called your place. I was scheduled for February 2nd, and I asked Richard on the phone if he could get me in sooner, because I was desperate. And you guys got me in a week or two sooner, got me in the 24th, which was yesterday. And so we made the arrangements, and I flew here, stayed in the hotel for a couple days, and was operated on yesterday. And yeah, it's well worth the trip. I apologize for getting emotional, but it's been a long trip to get here.
Well, we want you to get emotional, because it is an emotional thing. When you've been burdened with this pain for so long, and then suddenly it's gone, and you realize that life can be lived without that pain, you know, and that you can actually have a life without the pain.
Yeah.
So what are you going to do now that you don't have the back pain anymore?
Well, I'm going to get my life back together. I've got a new job, and they've saved it for me. My boss is wonderful, and I'm going to go back to work tomorrow, actually, if you can believe that.
Yeah.
And I'm going to start riding my bicycle again and getting healthy again.
Well, your surgery went very well. I don't know if you've watched it yet, but we were able to get in with a tiny 7mm 1/4" incision and fix both painful discs, and they were both very painful for you. And the pain was coming from a small tear that's located in the back of your disc where your herniation came out of. And that tear was just so inflamed, and we were able to clean out the herniation that was stuck in your tear and use the laser to debride it. And that's what the Deuk laser disc repair is. It's a debridement of the annular tear to eliminate back pain and leg symptoms. So we also have a cyst. We didn't treat your cyst. And do you think the cyst is causing any problems for you?
At this point, no. I don't think so, because all of my symptoms are gone. This morning when I woke up, I was a little nervous about getting out of bed. But that subsided quickly when I stood up and could stand up completely erect with no pain or bindage feeling in my back.
Yes, when I walked in and saw him this morning for the first time, the first thing your mother said was, "Look how straight he's standing." So they must have watched you suffer for a long time.
Oh yeah. Yeah, my mom's a great lady. I'm blessed to have her in my life. And then that's my stepfather, Jerry. He's a wonderful man. He and I are pilots. We fly together. We do a lot of things. And he's seen me go downhill. He knew something was wrong, you know.
How did you find out about us?
I've been seeing a chiropractor in Sacramento for 35 years. And 2 months ago, I started to really feel bad. And I would go to him. And after about a month of going to him, and going to my doctor for some pain management for these symptoms, I finally figured out that something else was wrong with me. And so I asked the chiropractor, what can we do, because what you're doing is not helping me. My doctor put me on pain meds, and they took some of the sharp pain away, but nothing was helping. And so, being kind of a mechanical engineer, I decided to look into how my back was put together. and I requested an MRI from my doctor and from my chiropractor. And so that took 3 weeks to schedule. That's a long story. And I finally got an MRI, and I looked at it myself and realized that I had a cyst of some sort and that I had some problems with my lower discs. And that's when my chiropractor told me about you. He said, get on the internet and do some research and then call these people. So I called your store. They gave me some information. I FedExed my package to you guys, and a week later you called me. And about a week or two later, I got here.
Wonderful.
So, yeah.
And here you are pain-free for the first time in many years.
Many years, many years.
Congratulations.
Yeah. Thank you.
Is there anything you want to say to your fans out there?
There is. This is a miracle. In Sacramento, everybody that I know said, why are you going? Why are you going to Florida? Why don't you find somebody in Sacramento? And I said, well, because I was referred to Dr. Deuk and I've done a bunch of research on him, and I just have a great feeling about him. Not only that, he personally called me on the telephone because I told his people that I had some questions. And that's what sealed the deal. And so it took a while to get here, but it was worth everything. And I would recommend anybody send your MRI to this guy, and if he can help you, he will. Okay? Thank you, Doc.
You're welcome, sir. It's my pleasure.
Yeah, absolutely.
All right, go enjoy the rest of your
All right,
life.
thank you.
And good morning, I'm Dr. Deuk here with one of my patients who traveled from Hawaii, the beautiful islands of Hawaii, to Deuk Spine Institute. You just had surgery for your back yesterday. How do you feel?
I feel surprisingly really good. Almost like nothing happened yesterday.
Yeah?
Yeah.
All right, well, you came here with a lot of back pain. Is that back pain still there?
Yeah, 7 years back pain. One spot in particular, my right side, that pain's been there forever. A lot of pinching, hard to do things, and it's gone.
That is awesome. So what kind of things, you said hard to do things, what kind of things were you limited with your back pain? What did it keep you from doing?
10 push-ups, I'd be sore for a day. 20.
Okay, oh, sorry we had to cut that testimonial short, but we want to get to the questions and answer session. And just so we all understand what's been done, this particular patient has had basically symptoms in his lower back related to back pain and leg symptoms that come from the nerves exiting through these holes called neuroforamen that are getting pinched or irritated here by the herniated discs. And he had this problem on both sides at L3-4, both sides at L4-5, and then on the right side at L5-S1. So I actually came from the back side and I went through the hole that was already there. I didn't make any new holes. And by the way, to go from the skin to the hole, you pass through muscle. And we use a dilator, which is like a pencil-shaped device made out of metal. You see me sometimes hammering on it. That doesn't cut the muscle, it spreads the muscle fibers. Much like this pin right here spreads the fibers on my cloak. It doesn't actually cut my fibers of my jacket. It spreads them apart because it's pointing, and it just gets between them and spreads them as it passes forward. It's called a dilator. Same thing with the pin. Pins are dilators. So the only real damage the laser surgery does to the body is it's a skin incision. That's it. We make the cut in the skin about 7 millimeters. The rest of it's all just spreading tissues apart. So we did the surgery. It went very well. We had no problems. A lot of people ask questions about the slippage of the bones, spondylolisthesis. It's only because I've done hundreds upon hundreds of these surgeries in patients with spondylolisthesis. I know they don't need the spondylolisthesis treated with fusion or any other treatment because their symptoms go away with just the laser surgery on the disc, and they don't need additional treatment. All right. I apologize for my stuffy voice. I had roto-rooter of my sinus just 4 days ago, and I'm still recovering, but it's been tough. And but I didn't want to let my patients down, so I'm here to get their surgeries done and answer your questions.
Yes, as of that, we have 2 questions. This first one comes from, excuse me, from Ben on YouTube, and they ask.
Hey Ben.
Ben asks, after you remove the herniation from the disc, how do you stabilize it so that it doesn't leak more jelly from the center after the surgery?
Ben, great question. So Ben asks a question we get quite a bit, right, Sanjay? If you look at the disc, all right, let's just say we take this disc out right here, just so we can look at it. Flip it up. The problem is in the back of the disc. And in the back of the disc, you can see there's something sticking up. And what that is it's actually inflammatory tissue and herniation combined. So what I do is I go in, I poke through that, push it back in, and I use a laser to clean it out and get rid of it. And what you're left with is a tear that can heal now, where it couldn't heal before. But the jelly in the center, it's not liquid like coffee. It's not liquid like this coffee here. It's really thick. And the best way to think about it is like shrimp, uncooked shrimp. So if you take uncooked shrimp and you imagine that uncooked shrimp is in the middle of the disc, it's not just going to leak out through the tear. You've got to squeeze on the bones and put pressure on the shrimp, and then it will find its way out through the tear. That's why I tell patients you can't lift over 40 pounds and you can't bend forward for 3 months after the surgery, because those activities would put pressure on the disc nucleus and push more of it out. And then you get a reherniation. Reherniation does happen with this surgery, 1 in 100. So 1% of the patients do get a reherniation.
Next question comes from Bobby on YouTube.
Hi, Bobby.
They ask, can the slip with PAR defect from L5 to S1 remain unstable and slip more to cause?
Yeah, so can the slip and PARS defect remain? I wouldn't say unstable, because it's not unstable. You've been told it's unstable by doctors that want to put screws in you. But if you take those doctors away and pretend they didn't exist for a moment, there's no instability. Instability is defined as excessive pain or neurological deficit that arises from a segment of the spine that's unstable with normal physiological loads. What are normal physiological loads? That means walking, standing, doing normal activities, not lifting things, but just normal walking, standing, sitting activities that a human being does. So after the surgery's over, these patients don't have back pain or weakness or numbness in their legs. Therefore, they don't have instability by definition. So somebody has polluted your mind with this idea of what instability is when there is no instability. There's just a slippage. Slippage is not instability.
And then lastly, as of now, it comes from Barb on YouTube.
Hey Barb, on YouTube.
Barb asks, how recent does the MRI need to be, and do you want it with or without contrast?
So Barb, we prefer to have your MRI about a year old. Maybe we'd accept up to a year and a half, as long as the symptoms haven't changed that much. And we do not need contrast ever. The MRI is without contrast. There's never any reason to get contrast on an MRI unless you suspect a tumor or an infection, which we don't normally.
That is it.
I hope you enjoyed the broadcast. I'm sorry I'm not at 100% to entertain you, but we'll be back in 45 minutes with a bilateral L4-5, L5-S1, DLDR on a patient with herniations and annular tear on both sides of the L4-5, L5-S1 disc with back pain and primarily leg symptoms. And he comes to us from the island of Grenada with his lovely wife. He'll be next. Thank you.